Although wet age-related macular degeneration, or AMD, accounts for less than 10% of all AMD cases, it causes about 90% of all AMD-related cases of legal blindness. Current therapies for wet AMD have been shown in clinical trials to slow vision loss, but they have not been shown to consistently increase vision above pre-treatment baseline levels. On average, vision continues to deteriorate, although the decline in vision is slower than it would be without therapy. Is it possible to improve this picture? Is it possible to increase visual acuity and visual function? The pathophysiology of wet AMD may provide a clue. Wet AMD results from the localized proliferation of abnormal, highly permeable choroidal vessels, resulting in damage to the retinal pigment epithelium, also known as RPE, photoreceptors, and other retinal cell layers that ultimately leads to vision loss. The normal expression of vascular endothelial growth factor, or VEGF, is essential to many processes in the body, including wound healing, and is a helpful adaptation to ischemia. However, the abnormal expression of vascular endothelial growth factor type A, or VEGF-A, is a major factor in the development of choroidal neovascularization and is strongly implicated in the pathogenesis of wet AMD. High concentrations of VEGF-A have been found in the RPE of choroidal neovascular membranes that have been surgically removed from AMD patients. In fact, in human clinical research, the choroidal VEGF-A concentration has directly correlated with the presence and severity of wet AMD. There are many VEGF-A isoforms, but all soluble isoforms and cleavage products have the same effect: promotion of new vessel growth and vascular leakage. When these isoforms bind to their receptors on nearby choroidal blood vessels, new blood vessels grow into the subretinal space. These highly permeable new blood vessels cause edema, causing vision to deteriorate. Additionally, formation of fibrous tissue and scarring may occur, causing macular distortion and central visual field defects. Clinical studies are currently investigating the importance of blocking all soluble isoforms of VEGF-A and penetrating all layers of the retina to reach the source of neovascularization and potentially restore vision lost to wet AMD. Research in anti-VEGF therapies is now focusing on a monoclonal antibody fragment specifically engineered for maximum affinity for VEGF-A. This antibody fragment acts extracellularly to provide complete inhibition of VEGF-A. This anti-VEGF antibody fragment effectively inhibits known isoforms and cleavage products of VEGF-A. A research challenge in anti-VEGF-A therapy is creating an agent that can reach the target tissue in the eye. An antibody fragment injected intravitreally has the pharmacological advantage of being able to diffuse throughout the retinal layers and reach the subretinal space. The antibody fragment forms a complex with all soluble isoforms of VEGF-A, preventing its interaction with VEGF receptors throughout the tissue. This may reduce vascular proliferation and permeability, which may decrease macular edema. By targeting the early stages of choroidal neovascularization and by blocking all soluble isoforms of VEGF-A, anti-VEGF-A therapies can potentially be effective in a broad range of patients with choroidal neovascularization due to AMD.